I don't know.
So for the next hour, we are going to be talking about the use of opioid agonist therapy for the treatment of opioid use disorders, specifically in maternity care settings. Kristen, if you could advance the slide, please. This is part of the SHOUT program. So this is a program where we are supporting hospitals around the country, and particularly with a focus in California, on improving our access to treatment for opioid use disorders in the hospital setting. Today's webinar will be focusing on buprenorphine and methadone in pregnancy. The speaker today is Kristen Harder, who's a pharmacist who works at Zuckerberg San Francisco General Hospital in the Women's Health Center. And I am Diana Kaffa. I'm going to be helping out with answering questions and moderating the discussion. Next slide, please. So we are going to have all attendees muted for the presentation. We are recording the presentation, and we will make the recordings available with the URL that you see on your screen. We will also email those out to everyone who's registered for today's webinar. Please feel free to share that recording with your colleagues if you want to use that to educate your institution. There are additional materials available at the URL that's on this presentation. We have guidelines to support the implementation of buprenorphine or methadone prescribing in the hospital, particularly, again, in this case, in the maternity care setting. We have slides available that you can use, again, for education. We have our old webinars available. We have an FAQ document and a P&T monograph that you can use to get these medications on formulary in your setting if you need support with that. To ask us questions, and we do encourage you to ask us questions throughout the presentation, please use the question tab in the GoToWebinar. If you type in your question there, we will be answering questions via chat throughout, and at the end we will also have some time where we share the questions with the presenters that you've posted and have the presenter answer those to the group. If you have logistical questions about the webinar, use the chat function instead of the question function and just chat to the host. Next slide. So SHOUT, as I mentioned, is a collaborative intended to increase access to addiction treatment nationwide, and specifically to offer inpatient methadone and buprenorphine with a bridge to maintenance therapy for people with opioid use disorders. The project is led by a group of hospital champions who are working to build skills throughout hospitals around the country in inpatient medicine, on surgical units, and in maternity wards. We are also specifically working to help people implement buprenorphine and methadone prescribing in their hospitals. Next slide. The timeline for this project. Many of you have been on prior webinars, and so you've seen this before. You know that we are getting close to wrapping up our didactic webinar series where we provide some education about the basics of doing this work. We're going to be moving into the logistical support sessions where we help you focus on actually implementing this in your practices. So we are going to begin in February a series of webinars designed to help you remove barriers that you're finding to implementation. So we will be available to answer people's questions about specific barriers they have, and it'll be more of an open dialogue about implementation strategies. In April and June, we'll be hosting monthly live discussion groups. We'll be sharing grand rounds templates so that people can do grand rounds in their own institutions to support implementation. And for select hospitals, and again, we've been asked by California Healthcare Foundation to focus on rural California hospitals, we will be available to actually go and present grand rounds to help with implementation. Next slide. Great. So let's get started. I want to introduce Kristen Harder, a highly skilled PharmD who has done a lot of work in treating opioid use disorder in pregnant women. So she will kick us off and talk about what we know about that area. Thanks, Kristen.
Great. Thanks so much, Diana. Welcome, everyone. I'm glad you could join us today. So I'm going to be talking about buprenorphine and methadone in pregnancy. Specifically, I know this is webinar number 4, so I'm not going to dwell too much on the specifics of buprenorphine and methadone in general, but it's all going to be geared towards pregnancy and the peripartum period, so also some postpartum information as well. Some quick disclosures. The slides that I'm using today were adapted with permission from both Dr. Hannah Snyder and Diana Kaffa. I am going to discuss some non-FDA uses for some medications that have evidence-based, but it's just something you need to know. And then this is not a substitute for clinical judgment. This is not the only approach. This is what we do here. Okay, today we're going to go through and describe the treatments that are used for opiate use disorder in both pregnant and postpartum women, compare the most commonly used medications for that in terms of efficacy, safety, and regulatory requirements. We're also going to look at pain management around delivery, especially whether that be C-section or labor, as that can be a challenge for those with opiate use disorder and are being treated for such. We're going to look at understanding factors that lead to NAS risk. And NAS would be the neonatal abstinence syndrome, which I'll go to in more detail in the future slides. We're going to discuss risks and benefits of breastfeeding in this population. And then just throughout the lecture, you'll be able to kind of understand the stressors of pregnancy and parenting with patients who have opiate use disorder. Anybody who has a child or worked with anybody who has children can know it's tough sometimes, and it can be just as tough, even more so for those with this condition. Really quickly, terminology. So we talk about G's and P's a lot, and gravida is how many times someone has been pregnant, and then para is how many times they've delivered or had an abortion or something of that. There's a 4-digit system that people can be aware of. So if you hear of someone saying G's and P's, it would be if someone had a G8, for instance, P1152, then that would mean they've been pregnant eight times. And they now have one of the babies was term, one of them was preterm. They've had 5 abortions, whether that's therapeutic or spontaneous, and then 2 of them would be living. It's just an example. Term the definition is really 37 weeks. However, 37 to 39 can be considered late preterm. Some people use that terminology. In California, here we consider viable those who are viable fetuses at 24 weeks, and that's different in every state. So someone who comes in and has is at 22 weeks or 23 weeks would be considered second trimester but pre-viable. And then one thing that I wanted to mention today, because it's very common throughout the country for us to use pregnancy categories, and that's the FDA categories that people have been using for decades, A, B, C, D, and X. And I just wanted people to be aware that the FDA actually removed pregnancy categories from labeling in June of 2015. And so I know that they're on a lot of resources like Lexicomp and Micromedics, and people use them a lot in papers, but unfortunately those categories are pretty vague for a lot of medications, especially when we look at like category C. And they're not always helpful for clinical decision making, and some people use those to make decisions which may not be accurate. So it's the pregnancy and lactation labeling rule was implemented, like I said, in 2015. And so now when you're talking about pregnancy risk or risks of medication in pregnancy and lactation, you can look at, and it'll say pregnancy considerations, lactation considerations, and then there also will be a section for those that are looking at female and male reproductive potential and whether or not a medication might have a problem or cause an issue with that. Pregnancy itself is a huge turning point for women who are using illicit opiates or any kind of illicit substance. It's often a huge time of change. They're very motivated, and a lot that has to do with the fact that they'd like to keep their baby, and they're worried about the results of this using illicit substances. on not only themselves but their child, and it's a really stressful time. And we always have to be considerate of the fact that there's two patients. So we have the mom, and sometimes there's more. If you have a multiple gestation, you can have multiple patients, not just two. We're the only service that a patient walks in with as one and goes out with multiple. The risks associated with illicit use are quite a few. There's some pretty significant negative medical and social consequences. Using illicit opiates for in the United States is actually much more common than expected. But it can cause preterm delivery, miscarriage, and IUFD, so intrauterine fetal demise, growth restriction and low birth weight, fetal and maternal exposure to HIV, hepatitis C, bacterial infections, and actually other diseases as well. If say, a patient is using needles to shoot, to inject heroin, say, into their veins, or they're practicing sort of risky, unsafe sexual practices, then they can be at risk for these things. And then infants with neonatal abstinence syndrome, that will occur, and that is always a concern. And then also the parent's inability to care for a child or children, which results usually in a CPS call, and the children or child involved being removed from the parents and the mom. So my first question or first poll is, do you have to report to CPS? And you guys can click, the questions are basically, the answers would be yes, no, one of the two. And I'll give everyone a minute or so to look at the results or find out what the results are. All right, did it go?
Yeah.
Did it go through?
Yeah, you've got the results up on the screen.
Oh, I do? Excellent. Oops. Click to open question pane. Oops, no, sorry.
So we have 56% of people said no and 44% of people said yes.
Excellent. So it actually, that's great. So I'm not sure where everyone is calling in from, but it is, the people are, it's shows kind of what the thought is now. It actually depends on where you are. So in California, there's no specific laws, and each hospital comes up with, we're all mandated reporters for abuse and that kind of thing. But really, it depends on the patient, and it depends on the caregivers involved in California. But in California in general, there aren't really any laws. In other states, though, it is considered a crime. Women are prosecuted, or they can be. It's considered child abuse in some states. It's grounds for civil commitment, and in some states it's mandated for reporting. What's interesting, though, is our goal for treating these women is to, or taking care of these women, is to get these patients into treatment so they can stop using these illicit substances, and they can improve not only their own care, but also their babies. And there's no evidence that there's any kind of maternal or fetal improvement when punishing women or putting them in jail. It doesn't increase morbidity, or it doesn't decrease morbidity or mortality on either the maternal or fetal side. And it actually creates barriers to prenatal care. And even more so, if a patient is placed in jail, they can actually go through for some pretty significant withdrawal themselves, which then puts the fetus in withdrawal and risk for preterm birth and stillbirth. So it's in California, there's no specific laws. If a lot of times for us, specifically at San Francisco General, if a patient is in treatment and meeting all their goals, then we actually don't necessarily call CPS, depending on how far it is in the delivery, or how far away they were from delivery when they started accessing care. There are 24 states where it is essentially illegal for a patient to use illicit substance while pregnant, and this is just sort of a map of where that is. So our next question that I want to go over is, what is the best way to manage opiate withdrawal in pregnancy? Are the questions showing up? Because I only see, yeah, there we go. the poll being open. So benzodiazepines would be one. Fortunately, on my side, unfortunately, I'm terribly sorry, I'm not seeing the poll answers. Ah, there we go. Benzodiazepines is A. Clonidine, Benadryl, Zofran, and Tylenol is B. Buprenorphine, C. And methadone is D. So I have about 30 more seconds. I'll let you guys answer some more. Excellent. Okay. Share polling results. So about 57% said buprenorphine and 43% said methadone. Excellent. So the correct answer is there isn't a perfect answer. Benzodiazepines is no. The clonidine, Benadryl, Zofran, and Tylenol, those are used usually to manage people who are going through withdrawal, and they may be under medically supervised withdrawal. Buprenorphine and methadone. So to be honest, it's really, there are benefits and there are pros and cons to each of those, and it's really based on the patient's decision, because as we all know, the most ineffective medication is one that's not taken. So if they're not willing to take buprenorphine, even though, as I'll show you, there's better evidence for reduction of severity and length of NAS, if the patient's not willing to take it, but they'd rather the methadone, then the methadone is going to be the best choice for a patient who's pregnant. This is just a reminder of the options that we have that are medication options. The methadone, the partial agonist buprenorphine, and then Naloxone, which is the antagonist. There's also the option, as I said, is medically supervised withdrawal. It's not necessarily recommended, and it's not recommended because it doesn't always work, and people have a very high rate of relapse, 59 to 90%. So it's not considered the standard of care. However, there was a recent report that experts off of CNN, they had in CNN Health, they had an article about experts saying that detoxing while pregnant can be safe, and that's absolutely true. If this is what a patient wants to do, even though you've explained the other options to them of what they can do for treatment of opiate use disorder, then you can just let them know that you can try this, and if it doesn't work, the door is always open to try other options. There are concerns for withdrawal causing preterm labor. However, there's very little evidence for that. And there's also the concern of having fetal stress and stillbirth as well, but the data on that is extremely limited. And also doing this, though, with the relapse rate, when they come off the medications potentially that they're on outside, that they're using, not under medical supervision, then they are at risk for going back and reusing and then overdosing, which is a concern. Naltrexone, it's not recommended. However, if someone wants to use it, it's not necessarily completely contraindicated in pregnancy. There's insufficient research to know what the outcomes are in terms of long-term outcomes, but also some short-term outcomes. There are a lot of reports of normal birth outcomes in humans. It's definitely less effective, as you've learned before, and it's the same in pregnancy. There's a higher relapse rate than the other two options. But patients who are very interested, they can try this. And patients who've been on naltrexone before, like in the preconception period and while they're pregnant, it's totally appropriate to consider continuing this medication and not necessarily transitioning to something else, especially if it's working for them. The opiate agonists, so the two that everyone had said that they were recommending one versus the other in pregnancy in the poll, there are the two. There's the methadone and buprenorphine. Both are FDA approved for opiate use disorder in pregnancy. The goal is always the same for pregnant or not. It's maintenance, not detox, and they're very highly effective. They're exceptionally effective for both non-pregnant and pregnant women, and they're great options to discuss with your patients. They're recommended by a lot of different national guidelines and organizations. So ACOG, the American College of Obstetrics and Gynecology, SAMHSA, who they all recommend using opiate agonist therapy or buprenorphine or methadone. It reduces opiate use, prevents relapse, improves pregnancy outcomes, and prevents overdose deaths, which is very good. And in addition, preventing HIV transmission along with the Hep C and a lot of other communicable diseases. And then it supports family function and appropriate parenting as well. Choosing between methadone and buprenorphine. So if you're counseling a patient who's pregnant about these two options, basically there's three things you have to keep in mind. Is the patient medically eligible? Do they have any contraindications to the medication? Are they available? Is the buprenorphine or methadone available? Do they live close by an opiate treatment center for the methadone? Or is there anyone near the area with a X number for their licensure to be able to prescribe buprenorphine? And then determining the patient's preference. And that's probably the most important one, because like I said, if the most ineffective medication is one that's not taken. And so it's really important, and probably the most important, to work with the patient to determine which medication she prefers and not just tell her what you think she should do. The cautions for buprenorphine, so in pregnancy and honestly in the general population as well, allergies, so if they're allergic to it, then something they can't have. If they have increased LFT, so liver function tests that are greater than 5 times the upper limit of normal. This is especially important in patients who may have preeclampsia, say, and they have already very elevated enzymes. You probably don't want to exacerbate that, but it's not necessarily a contraindication. Having a history of binge use of alcohol or benzodiazepines, and that has a lot to do with the fact that the ceiling effect that you learned about in other webinars diminishes once you start using other sedatives. Injection benzodiazepines, and then having a history of diverting buprenorphine. Those patients, it's not necessarily that you can't do buprenorphine. It's more of a issue of it might be preferable for them to go to like an opiate treatment program that may also give buprenorphine, so they can have, direct observed therapy or DOT treatment if they're still interested in the buprenorphine. In terms of methadone, allergy, prolonged QT, so if they have an allergy, it's not something they can do, then that's out. But prolonged QT, that can be an issue, and it can be an issue especially in pregnancy. So we recommend that a baseline QT be done before starting methadone, especially in pregnancy. Sometimes patients are on other medications that can exacerbate or prolong QT as well, and they can be on a bunch of different ones. So things like on Dancitron, so for our hyperemesis gravidarium patients or ones that need it in general for nausea and vomiting in pregnancy, they can also be on metoclopramide. And then my patient population in particular has a higher incidence of psychiatric conditions, so Seroquel, Haldol, those type of things can exacerbate QT or cause it to prolong. So the thought is if you get a baseline and you know everything's okay, then adding that methadone may be safe. It's just a caution. And then recent use of benzodiazepines, alcohol, or other sedatives, and that has to do with the respiratory depression that you've learned about in the other webinars. Preferences, again, it's always based on what the patient will take. And so when you're trying to counsel a patient on, like say that there is an option and there are no contraindications and there's options in the community to both do methadone or buprenorphine, then it's important to figure out what the patient would like and to highlight aspects of the decision process that may make them want to go and use buprenorphine over methadone, for instance, or the other way around. So identifying factors most important to the patient, so the fetal impact, how it will impact the fetus, and then also after the baby's born, maternal outcomes, side effects, ease of use is important to look at. So as we know with the opiate treatment programs that you need to go every day versus buprenorphine after a while, or maybe even after a couple weeks, don't have to go in every day to see a provider. And then previous experience or experience of friends and family. So sometimes patients go, yeah, my sister takes buprenorphine and she loves it, I'd like to try that. And that can be important as a decision point for a patient as well. So what I'd like to do is go through this chart of comparing the two, buprenorphine and methadone, and we'll start with efficacy. So efficacy, you can use these charts when you're counseling patients as well to talk to them about the different aspects of what's important to them. So talking through these differences helps patients and clinicians choose the most appropriate medication. Overall, the effectiveness is essentially equivalent as long as the patient takes it. They both result in increased opiate abstinence, reduced quantity of opiate use, reduction in injection use, and then overall reduction in deaths and mortality, which is good for both fronts. When you're looking at retention and treatment, they are a little bit different. So in general, patients, there's something called the Mother Trial that you may have or have not heard of, and it was a big multi-center, double-blind, randomized controlled trial in 2010 that looked at comparison of various points of methadone versus buprenorphine in pregnancy. And one of the things that they looked at had an N of 175, and they looked at whether or not a patient had better retention if they were using buprenorphine for their treatment of OUD or methadone. And the methadone, 82% of patients were retained in treatment versus only 67% of those patients who are in buprenorphine. However, the study authors did note that most buprenorphine dropouts occurred during the induction phase, and that once patients had completed induction, their retention rates are similar to those being treated with methadone. So if a patient can get through the induction period, and as you learned in the other webinars, there's some withdrawal that needs to happen for that to happen, and sometimes that's not tolerable for patients. The retention and treatment is pretty similar, and especially once a patient is on 16 milligrams or above in non-pregnant patients, they found that that there was the same retention rate to people in that were also in a methadone, using methadone for their OUD. So the true impact of a medication choice on retention is not entirely clear, but it's important to at least acknowledge this to patients so that they're aware that, especially during the induction phase, that it may be difficult to stay with buprenorphine for some. Neonatal outcomes, this is very important for patients as well. Both buprenorphine and methadone do reduce the chances of preterm birth and low birth weight. And we don't really know what the mechanism is for that completely. It's probably multifactorial. For instance, stabilizing the dose of opiates in the mom's serum, so the levels being stable is helpful. And then the medications, so that helps reduce withdrawal to the neonate as well. And then the stabilizing effects of medications also contribute to better nutrition, better engagement in prenatal care. However, when the two medications are compared in terms of preterm delivery or preterm birth and low birth weight outcomes, studies examining the fetal activity and fetal heart rate variability as well, which I didn't put in this chart, but that's also something to look at. But when you compare methadone with buprenorphine, they have a later average gestational age at birth weight and a higher average birth weight for those in the buprenorphine, using buprenorphine for their medication treatment. And in addition, the fetal activity and heart rate variability in buprenorphine tends to be higher than it is for methadone. However, in terms of how clinically significant that is, we're not entirely sure. It's just something to think about. Also regarding patients' neonatal outcomes is the neonatal abstinence syndrome. So that's any opiate exposure can cause this. It's including the methadone, buprenorphine that are used to treat opiate use disorder. It results in a baby coming, basically when they're delivered, they now no longer have the opiate on board and they go through a withdrawal. So symptoms that you'll see are really high-pitched crying, irritability, trouble feeding, GI disturbances, yawning, sweating, and sneezing, low-grade fevers, increased respiratory rate. And then when it's really bad, it can cause seizures, failure to thrive, and death. It's diagnosed using the Finnegan scale and occur pretty much anywhere between days 1 and through 5+. So sometimes over a week, you can see a patient, a new baby, have neonatal abstinence syndrome. And so the American Academy of Pediatrics recommends that that you should monitor these patients for at least 5 to 7 days before discharging them, which can be hard for mom, especially if she is delivers and is fine and is able to be discharged. It can be hard for the mom to know that that baby needs to stay in the NICU or in whatever well baby nursery or NICU for at least 7 days. The treatment of choice is liquid morphine, oral usually, although you can do IV. Some places do tincture of opium, and other places when it gets really severe, they can do a combo of clonidine and phenobarb. It's out of the scope of this lecture to go over those, but I just wanted to mention that the baby will have to be on some sort of opiate to help with the withdrawal and to wean them off of that so that they don't have neonatal abstinence syndrome anymore. The long-term outcomes for NAS, we're not entirely sure. There are some links to poor performances in school and ADHD, but we don't know for sure what the long-term outcomes are. We do let patient moms know that one of the best options to help for them to help their baby is to room in if they can, frequent skin-to-skin contact, breastfeeding, minimizing environmental stimuli, comforting their baby by swaying, rocking, using a pacifier, and actively promoting mother-infant bonding by doing these things. And that is often a help to moms to know that they can do something to help reduce the severity and length of NAS. Every 25 minutes, a baby is born suffering from opioid withdrawal, so it's a pretty significant situation or condition. And then, in addition, it's very expensive. The babies stay in the hospital for longer periods of time, and it tends to cost quite a bit more. So the more we can reduce it, the better. However, both of them are going to help reduce NAS too, as opposed to using illicit substances potentially. NAS2, in terms of, I have another section on that in terms of the mother study. If you look at how long a baby is hospitalized, if their mom's using buprenorphine for opiate use disorder versus methadone, it's shorter, how the average length of stay, and then also how much morphine is required. So that kind of is a surrogate marker for how severe the NAS is. There's multiple studies that have also found the duration and severity of NAS are reduced in newborns born to mothers on buprenorphine relative to methadone. It's not just the mother study, but the mother study is the largest randomized controlled trial, controlled trial comparing methadone and buprenorphine. Okay, and then visit frequency. This is something that can be important for parents. A lot of parents this isn't just their first baby. We do have patients who they have this condition, and they potentially have it chronically, and this is baby number 3, 4, 5, and they're still in their custody. So sometimes visit frequency can be something that could be a barrier to patients either accessing care for buprenorphine or methadone. So the visit frequency, I'm not going to dwell on it, but it's it's the same as it is for non-pregnant patients. Daily for methadone, daily and weekly initially, and then spaced out for buprenorphine. And then location of care, so that's also important for some patients, especially when you're pregnant. You have a lot of prenatal visits, and so if the patient can combine that with their opiate use disorder check-in, say buprenorphine, that can be a benefit to a lot of patients, especially if it's going to interfere with potentially their childcare, their work, their school. It's important for some patients to do that. And then, of course, the methadone or the method is dispensed in a methadone clinic every day or an OTP. Oops. And then sedation. The next slide, it kind of included both. So sedation, buprenorphine's less sedating. However, again, that goes away if someone's concomitantly taking benzodiazepines or alcohol. And then initiation. So some patients are scared of the withdrawal, potentially, that they need to go through to start buprenorphine versus methadone. There's really no withdrawal required at all. And so some patients would prefer that over the other. Overall, though, both improve pregnancy outcomes relative to no medication. Both carry NAS risks, and their shared decision-making is always the key for this group of patients. So if the decision is shared, then they take more, it's better, they are more willing to engage in care. Counseling women about NAS, there's a few things that I do want to talk about outside of buprenorphine and methadone. First, though, is that this risk of NAS and severity of NAS do not correlate with opiate use disorder treatment with buprenorphine or methadone. So some patients think that if they are on methadone or buprenorphine, that they should self-reduce their medication because they're worried that it's going to cause NAS. The higher the doses are, the more NAS it's going to cause, and that's just not true. Severity does correlate, however, with tobacco use. The fetal compartment sees anywhere from 1.2 to 5 times the amount of tobacco, or nicotine really, that the mom sees. So they can go through a pretty significant withdrawal if mom is smoking or using some sort of tobacco. SSRIs can cause issues, benzodiazepines, gabapentin, other psychiatric medications as well, like Haldol and Seroquel. SNRIs too, duloxetine, venlafaxine, they can cause NAS, and if you have a patient who's on several of these different medications, it's very important to tell pediatrics when the baby's born so that they're aware of this as well. Rooming in, skin-to-skin, breastfeeding, all reduce incidence and severity of NAS, and again, that helps mom feel like she has an ability to help her baby once the baby's born. All right, we're going to go on to buprenorphine. Buprenorphine, there's the monoproduct and the dual product, the buprenorphine with naloxone. The dual product is not necessarily a standard of care. We always, for pregnancy, use just buprenorphine, and there's a couple reasons for that. One is that the naloxone it's not really well known what the outcomes are for the baby and how that works with development. So there are some thoughts that endogenous opiates are mediators of several neurological functions, and that if you block these endogenous opiates, then it can cause potentially some issue with the brain development of the baby. However, that's not been proved anywhere, and we still don't know the exact outcome for that. There's also another thought that if you allow patients to have buprenorphine and naloxone and they crush it and shoot it up, that it would cause significant withdrawal in the mom and therefore the fetus. And that's just, that's not been really proven at all. It's just a thought out there. But really the real reason is we just don't know what the naloxone will do. And so since there's just the buprenorphine component, that it's something that we can use for our pregnant patients to reduce any kind of risk that we're unaware of. Prescribing buprenorphine is the same as it is in pregnancy. There's really no difference, so I'm not going to dwell on that. I just wanted to let you guys know that that is the case. Yeah, okay. And then in terms of the dosing is actually also identical initially for those who are pregnant versus those that are not. And I put this algorithm up here as one example. There's many, and your other webinars went through some of that. Dose increases. This is the one difference, though, that is between pregnant and non-pregnant patients. Pregnant patients, as they go through their various trimesters, especially in the end of the second trimester and the third trimester, they often need dose increases or split dosing of buprenorphine to titrate. So what we do is we tell people to help titrate to cravings and or withdrawal. And so the reason why that they tend to need higher dosing is because of all the PK changes or pharmacokinetic changes in pregnancy. So that would be an increase in volume of distribution, increase in liver enzyme activity, and decreases in half-life. And so that's why they need it. A lot of times they need to split it like a dose in the AM or PM, and sometimes patients do need TID dosing. And it's often a good idea to ask an expert whether or not what to do, but you'll notice a lot of women will notice anecdotally, for us anyway, that we see, that's extremely common that a lot of women will notice that they have more cravings and need higher dosing and or split dosing. Adjunctive treatments, you've learned about this before. All I wanted to do is say here basically is that we do not use NSAIDs in pregnancy. It causes closer to term, around 30 to 32 weeks, it can cause the closure of the ductus arteriosus in the neonate, so we stay away from NSAIDs. However, in the postpartum period, NSAIDs are fine. So I just wanted to put that out there so people are aware. Another thing too is that in terms of adjunctive treatment, Benadryl is very commonly used. I recommend not to allow your patient, or not to give it IV if you can avoid it. It can cause a little bit of a high, and we have patients that sometimes come in asking for it. IM and PO are fine. If patients are, ondansetron comes in an oral dissolving tablet and also an injection, and that helps for patients who feel nauseous. But the biggest point, take-home point, is that NSAIDs are a no-no in pregnancy, but they're okay postpartum. Troubleshooting are things to think about in general. What if a patient has been off of opioids or is in jail but is worried about relapse? You can start a low dose in absence of withdrawal, and that's fine. If a patient last took heroin 24 hours ago but is still not in withdrawal, what do? You should ask her if she took methadone, or because it might not be in withdrawal because the methadone is long acting. And then a question to think about is, does she use frequently enough to have physical dependence? And if she doesn't, then she's not going to be in withdrawal. What if we cause precipitated withdrawal, which is a concern with buprenorphine? You can give another dose of buprenorphine, and that may help. And if that doesn't work, or if the fetus is in distress, and a little bit of fentanyl could potentially help with that as well. If a patient still has withdrawal symptoms after taking 16 milligrams on day 1, the max we recommend here is 16 milligrams on day 1. We give adjunctive therapy, so that list before, ondansetron, Zofran, clonidine, those are the things we use to manage that until the next day. What if you give another 2 or 4 milligram dose close to the start of the next morning? So as you've learned in the other webinars, it's good to take the last 24 hours, add that up, and then start that as the next day's dose. But if you're close enough to the next dose, instead of doing a 2 to 4 milligram dose and then adding that on and then giving another 2 to 4 milligram dose, you can just add up the total and then add on another 2 to 4 milligrams close to the start of the next morning dose, and that should work. What if she wants to transition from methadone to buprenorphine? This is not recommended. However, it's doable. It's just something that you would probably want to consult an expert for, because they do have to go through withdrawal initially in order to transition over. We unfortunately here haven't had much success with it, but it's not necessarily contraindicated. Methadone. Methadone, what about it? So similar, almost identical to the patients who are not pregnant. However, as I'll go through in a subsequent slide, there is an issue with patients needing in the 2nd and 3rd trimester higher in doses and or split dosing. And so for the first 3 months, the patient legally needs to come in every day to the Opiate Treatment Center to be able to get their dosing. However, you can apply for a waiver for take-homes as needed for the 2nd and 3rd trimester. So that's the only main difference, really. Everything else is pretty much the same, although some patients also like methadone because the opiate treatment programs offer often vocational services, case management. Some offer parenting support and prenatal care and a lot of other wraparound services that can be very beneficial to patients. And then we also here at ZSFG got approval from the DEA to, so you're not supposed to dispense methadone to people outside of the opiate use or opiate treatment program in the outpatient side. However, depending on how your hospital is set up, a lot of hospitals have what they call a triage unit. So if a patient thinks they're going to deliver or they think their water broke, they can come in and instead of fully admitting them, they're in like this outpatient area on an inpatient unit. And so we have gotten permission from the DEA to be able to give a methadone dose to these patients if they're in our triage unit for a long period of time and cannot make their appointment. And that's because it's associated directly with an inpatient hospital. And so that's appropriate for patients who are pregnant. Methadone, the only thing I wanted to say basically is as the pregnancy continues, there are changes in PK. However, the risk of overdose with induction is still the same as it is for non-pregnant patients. You can still overdose a pregnant woman on methadone. And then in terms of dosing, it's pretty much the same. There's not a lot of differences. There's different mechanisms by which people, or different ways people do an induction, but it should be essentially the same as it is for those who are not pregnant. Dose increases, as I said, though, in the second and third trimester, methadone metabolism is accelerated, and the tissue storage is also altered. There's a larger volume of distribution, so that often means that patients usually require dosing that's either BID or TID, is what I see the most frequently. The most I've seen is someone on 220 milligrams BID of methadone. And that's very high, and she had other comorbidities, including sickle cell and cancer. But the point is that they often need to increase the amount and/or the frequency by which they do it. However, those dose increases have definitively showed a reduction in illicit opiate use and improved neonatal outcomes, so it's not wrong to do. Pain control quickly in labor. You've had another webinar on pain control around acute in things like surgery or acute pain for whatever reason. So there's a few differences, but mostly it's the same. So full dose of buprenorphine or methadone for labor and postpartum is recommended. In terms of labor, neuraxial, regional, and local anesthesia is preferable when a patient comes in is actually in labor. Epidurals and spinal analgesia work very well, and giving an early epidural would be great. We have nitrous oxide here. That is nitrous, it's fantastic. A lot of patients use that, and that doesn't cause any issues with the methadone or buprenorphine. There's non-pharmacological pain control options with patients who are in labor, one of which is doing sub-Q sterile water for these patients, and so that sometimes works for them. Fentanyl does pretty well. We have the same dosing for non-labor as we would for non-opiate use disorder patients as we would for ones who have it. Non-opiate adjuncts are great, like ketamine or dexmedetomidine, and that's always needs to be in consideration with OB anesthesia and consultation with them. There's also some data that giving gabapentin 600 milligrams or a gram of Tylenol before cesarean section, about half an hour before, can reduce postoperative pain. We found that here. There's some data on it. There's also actually some data of giving a vitamin B complex in addition to the gabapentin to reduce postoperative pain as well. So some places institute that. It's safe, but all of that is safe in pregnancy, and some don't. But it definitely reduces the amount of opiates that are necessary after delivery, especially with C-section. Discontinuing buprenorphine is thought to potentially in the basically the perioperative period, or if you know you have a patient that's going to have a scheduled C-section. Some people like to discontinue buprenorphine and then give full opiates during the procedure and then retitrate someone back up on buprenorphine afterwards. This isn't really recommended. It can be done, but it's not really recommended. And if it is done, it has to be done gradually over weeks. And then rapid tapers, because rapidly tapering increases the risk of relapse. But also the problem is no one has a crystal ball of when someone's going to deliver. So even if you have a planned C-section, you might have someone who has severe preeclampsia, needs to deliver earlier, has some sort of complication, and so it's not ideal. And we have not had a problem with precipitate withdrawal by giving the patient's normal dose, as that's their baseline, and then adding what we need to for pain control in terms of opiates after. The postpartum period, we sometimes maintain patients on an epidural in consultation with OB anesthesia. Non-opiates, especially NSAIDs and acetaminophen, are really, really beneficial. You can either use ibuprofen or naproxen. Either one work great. And then in discharge, you want to make sure that If a patient still has acute pain, especially if they've had a cesarean section or they had a 4th-degree tear, or even a 3rd-degree tear, it's important to make sure that you control their pain. These patients are hyperalgesic, and they have a lot of anxiety too sometimes, which can cause them to have more pain. And so you definitely don't want to, you want to prescribe opiates if necessary, just like you would if patients don't have an opiate use disorder. But we tend to only prescribe they usually only need about 3 days worth, and we don't necessarily have people that abuse that. They actually do need it for their open abdominal surgery that they just had, or their tear. All right, so question, breastfeeding on opiate agonist therapy, is it safe? And the question is yes, no, or maybe. And this is an interesting topic because some people have differing opinions. Great. All right, so 60% said yes, 4% no, and 36% said maybe. This is awesome. So the answer really is yes, it is. Depending on whether or not the patient is using, oops, I have to close that. Depending on whether or not the patient is using illicit substances, and if they're not, it's actually very safe to breastfeed while a patient is on either methadone or buprenorphine for treatment of their opiate use disorder. It's strongly recommended by a lot of people, or a lot of organizations, including ACOG and the Academy of Breastfeeding Medicine and the American Academy of Pediatrics. The amount of methadone or buprenorphine in breast milk is actually pretty negligible. It does, though, reduce the NAS for babies, both severity and length. However, that's most likely through frequent suckling and cuddling and quiet and soothing of the baby with mom or another caregiver. So there's little concern, though, for infant sedation, which is good because of how little gets in the breast milk. At the same time, like I said, we know that it reduces NAS. And I put up here, so LactMed is a great resource for, it's run by the NIH about how much of various medications get into breast milk, and so it's, as you can see, it's really little, and the only contraindication for it would be if a woman is concurrently using illicit substances or using alcohol heavily, because that could get passed on to the breast milk and then cause adverse effects in the baby. Also, just as a thought too, buprenorphine in breast milk, it's very low levels, but it's also very poorly bioavailable, especially in infants. And so that's not a concern as well. However, we do tell patients that there is a little bit that can get into the breast milk and it can get into baby. And if that's the case, or if they're worried, we always say you need to monitor for drowsiness and if they're gaining enough weight, and you know, if they're if they don't have these issues, then it's not really going to be an issue for the baby. All right, so the next one, which of the following will not help a patient reduce the risk severity of NAS in her newborn? And the answers are smoking cessation, breastfeeding, rooming in with frequent skin-to-skin contact, reducing her buprenorphine or methadone, and keeping the lights low and the room quiet. So, okay. All right, so poll is closed. So the correct answer is D, is reducing her buprenorphine or methadone. We know that it doesn't matter what the dose is. It's not necessarily going to dictate how severe the NAS is or how long, or whether or not it happens. So that's correct. Smoking cessation will help reduce NAS. Breastfeeding and the rest of them, you guys have it. You're all correct. Great. Dose adjustments postpartum. So there's a lot of really big changes that happen, physically, in addition, obviously, to mentally and psychologically, physically. There's a lot of changes when you become pregnant. But afterwards, the woman's body does go back to pre-pregnancy state eventually, and so in terms of their pharmacokinetics, so the liver enzymes won't be so active, the volume of distribution will be reduced, and so they do need during this, usually between the first 12 weeks postpartum, they'll need to reduce their dosing to their pre-pregnancy or first trimester levels of opiates. And that can happen right away, and it can also happen at anywhere up to 12 weeks. The hepatic metabolism normalizes around 6 weeks postpartum. And so things we tell people to look for are somnolent, so they may be they may be like very, very sleepy, or more so than would be normal for already being sleep deprived from taking care of a newborn. Depression, that happens in up to 16% of patients on opiate use, or who have opiate use disorder. There's other stats of up to 25%. To be honest, most people, I think, have some sort of degree of postpartum depression because they're so sleep deprived for caring for this little newborn, and that's why we call it the fourth trimester for the first 3 months postpartum. But it's something to look for, and then relapsing, especially 3 to 6 months postpartum, is something to look for because the postpartum period is very difficult. But it's good to keep a close eye on patients postpartum to make sure that you're titrating their dose appropriately, so you're not putting them at risk with, especially methadone for, say, respiratory depression, and that you are, just titrating that appropriately. A few last points that I wanted to quickly go over in the last couple minutes that we have is just really quickly, polysubstance use. What do you do with patients who are pregnant who are also drinking a lot of alcohol or on benzodiazepines? So the thought was that you'd have to help with medication for them, just treat the opiate first, or just treat them getting off benzodiazepines first, alcohol, and that's just not true. As long as you have close monitoring and support, you can actually taper these other medications if they're using benzodiazepines or alcohol, in addition to while you initiate methadone and buprenorphine. About 50% of patients also abuse other substances, so it is a concern, and it's something that you may see. It's always good to get an expert consult if you can. And then the next thing I want to talk about is urine drug testing. So it's a little bit different in pregnancy, because you actually need to obtain a verbal consent in California to get a UTOX for patients that are pregnant. There's a couple issues with it. It's very useful for monitoring treatment stability, whether or not they're taking it, and if they're not taking other things. The other thing is because you have to get verbal consent, it's always a good idea to tell patients that it helps you build a good CPS case. So if they're worried about CPS being called, if they can show a lot of negative UTOXs, then it actually helps their case for keeping the baby. However, the UTOXs generally are done by immunoassay, and they're subject to false positives and false negatives, which can be concerning, especially for methamphetamines, although this is not, a talk on that. Up to 10% of patients who have a positive UTOX, so it can be negative for methamphetamine, or it can be a false positive for methamphetamines up to 10% of the time. So things like labetalol, ranitidine, metformin, and promethazine can all cause false positives. So the take-home point is that these tests are presumptive until confirmatory testing with gas chromatography or mass spec is done. And until that time, it's good not to necessarily make rash decisions about not breastfeeding, especially if a patient had really uncontrolled hypertension and needed a lot of labetalol right before delivery. She might actually come back with a false positive for a medication. And then in terms of discharging and other aspects of peripartum care, discharging, kind of the same, it's actually the same as it is for non-pregnant patients, finding local providers on day one, and doing an intake prior to discharge for methadone, and an intake as soon as possible for buprenorphine to make sure that they have a continuation of care. There's also the same 3-day rule that there is with non-pregnant patients. The thing that I want to hone in though onto is you can definitely prescribe naloxone for pregnant patients. Look, we don't want them to overdose, and this is a safety measure for them. And then PrEP. PrEP is something I like to look at the whole picture of a patient, especially if a patient is engaging in risky sexual behavior or injecting heroin, let's say. They can be at risk for getting HIV. And HIV is the only STD that can be prevented through medication administration, or we use Truvada. That's sort of the standard of care. It's only a once daily dose. It's very safe in pregnancy. It's widely used and very well tolerated. It's not associated with any adverse pregnancy, fetal, or neonatal outcomes, and very low levels are secreted in breast milk. WHO and the Center for Disease Control recommend it a lot. And so if you have a patient who's at risk, I just want to put it in the back of your mind that it's a really good idea to think about PrEP, especially because if a patient seroconverts during pregnancy, she has a much higher risk of passing that virus, that HIV virus, onto her fetus than she would if she had been HIV positive before the pregnancy. And then tobacco cessation, very important, and postpartum depression and anxiety, looking for those is very, very important too in the postpartum period, and making sure you monitor for that. And then lastly, I just wanted to quickly say something about drug information resources. I'm a pharmacist, and so I like to share how to look up information, especially in light of the fact that the FDA categories for drugs aren't ideal. But ReproTox is an excellent resource. It basically has all of the most up-to-date literature on every substance out there, including chemicals. So things like asbestos or tar, you can actually look that up. It does cost money, so you can look to see if your institution can pay for it. LactMed is free, and it is available through the NIH. And has a lot of information on lactation. ReproTox delineates things off of first trimester, second trimester, third trimester, lactation, female and male reproduction effects, and animal studies. So it's very, very comprehensive. The Infant Risk Center is run by an individual down in Texas. He's a pharmacist who has a lot of really good information on safety of medications in lactation. Lexicomp, Micromedics. Oh, sorry.
Kristen, we're just getting to the end of time, and so I want to make sure we wrap up for people so they can get out.
Yeah, thank you. Oh, sorry, thank you. So, yeah, and then the Hive resource is just for information on PrEP. And then key points, I'll just leave those up there, and that's it. So
Great.
Thank you for joining us today.
Yeah, Thank you, Kristen. Sorry to cut you off there at the end. I do know that so many people have to run off to clinic.
Sure.
Yeah, and thanks to everyone for joining us and for all your questions. I tried to go through and answer people's questions individually, but because we won't have time for questions, we're going to go ahead and take any of the main questions that got asked, put them in FAQs, email them out to everyone. And for those, I think there are 2 people who I didn't answer your questions yet. We will send you emails with the answers to your questions as well. And if you could advance the slide, Kristen.
Oh, of course. Yep. Okay.
We do have the implementation webinars coming up in January and February. So in a webinar on logistics in the hospital setting on January 17th, and then February webinar on removing barriers to implementation, and the same in March. And we welcome you to join us for those. And on the next slide,
okay.
If you could advance, thank you. Here are our email addresses. Please feel free to reach out to us if you have specific questions about what we talked about today, or if you want to get in touch with the Project Shout Coalition, there's the email there. We also encourage you to call a UCSF substance use warm line if you ever have cases where you just need someone to walk you through a complex decision. They're available all week long, and they would love to hear from you and support you through your work. I think there may be one more slide.
Yeah, just the references.
Great. Thank you so much, and do feel free to get in touch.